Hello and welcome to another Piper Pod. Today we're going to continue along with pharmacology and we're going to look at medications associated with hyperlipidemia. Now, hyperlipidemia and also hypercholesterolemia are conditions in which there are high levels of lipids or cholesterol found in the blood. Now, this is quite a common disorder. It has many causes that we'll talk about soon. It is quite prevalent in the military, and there's a few personnel that you will find, especially as they get older, that will be on these medications. So throughout this presentation we're going to look at considerations for hyperlipidemia, a bit of the pathophysiology of how it's caused, monitoring requirements, and then of course medication that is required to try and fix these conditions. So before we start off, we'll look at what causes high cholesterol in the body. Now, if you remember back to anatomy physiology, it was stated that cholesterol itself, only 15% of cholesterol actually comes from the diet. So the nice obvious one that everyone turns to, which is high carb or sugared diet, only accounts for 15% of the actual cholesterol that is produced. Now, things that may not be as obvious is things like poor thyroid function. Now, the reason that increases cholesterol, especially lipids, is because thyroid is essentially responsible for the metabolism within all cells, which includes fat metabolism. So if you have a low amount of thyroid hormones, then you are going to need less transferring of fatty acids and cholesterol to the actual cells in order to use it for metabolism. Now, when we look at allergies and infections, those two pretty much go hand in hand together, and there's a very strong link associated with LDL cholesterol and the inflammatory state. So inflammation caused from food allergies or infections is going to cause your cholesterol to rise. Now, clinical problems associated with your liver is kind of obvious. It's your liver is responsible for producing your cholesterol and obviously synthesizing fats. So if you have liver disturbances, there's going to be a disruption in the actual control formation of these lipoproteins and fatty acids. A few that may not make a lot of sense is kidney disease. Now, I'm not going to go into too much details with kidney disease, but just know that there is a huge link associated with renal failure causing high cholesterol and high cholesterol causing renal failure. So it's a bit of a loop going around that way. Now, in association with leaky gut, now that essentially means that when someone has a small hole in the bowel, they're going to leak products into the environment. Now, what happens in that case is you actually have a exotoxic binding agent with the enzymes responsible for the production of cholesterol. So it's these exotoxins that are being produced by the bacteria synthesizing in the bowel that actually cause your cholesterol to rise. Now, in the event that losing weight causes high cholesterol, this is a little bit confusing and a lot of people get a bit caught up with it, because obviously there was a very strong link between obesity and high fat diets and things like that that are associated with high cholesterol and hyperlipidemia. But because fat, triglycerides and cholesterol or pseudocholesterol is stored in muscles and in adipose tissue and the liver, when you start eating better and you start losing weight, these fat stores get broken down and cholesterol is actually released into the body. Now, the body will never actually use cholesterol as an energy source. So initially, when you start losing weight, your cholesterol level can rise. So it's something that people need to be aware of if they're starting to lose weight and get better exercise and diet because of cholesterol, that there may be an initial rise in the cholesterol levels because they're being released from the fatty acids and they're unable to be utilized as energy sources. Now, this will correct itself. The body will just stop producing cholesterol in the presence of cholesterol, obviously, and then over time it will regulate itself as it dissipates. So there are all the causes of cholesterol, and the reason high cholesterol is a problem is because of the associated plaque formation, okay, or erythemas formation. Now, we've spoken before in pathophysiology about plaque formation and atherosclerosis, but that is absolutely the consideration that is needed to be taken into account when you're dealing with high cholesterol levels. So plaques, or the result of endothelial destruction, which causes collagen fiber to be released into the lumen. From there we have an infiltration of foam cells and migration of actual leukocytes, and then we start getting repair of proliferation, and cholesterol comes along and forms part of that plaque. So the plaque is a mixture of fats, cholesterol and collagen fibers all mixed together. And obviously from that we have a huge risk associated with ischemia, so cerebral, myocardial, renal ischemia, to name a few, and also the risks associated with emboli and things like that. So that's why having high cholesterol, blood cholesterol, is a problem, because the more physical particles of cholesterol you have floating around your body, the more likely you are to not only form the plaques but also reinforce or add to the plaques that are actually formed. Okay, so let's have a look at what cholesterol is, okay, and not only that, but look at other blood tests associated with monitoring high cholesterol. So when we use the term cholesterol as it is, we're usually talking about two main proteins, okay, and that is your high density and low density lipoproteins. Now they're associated with either HDLs or LDL cholesterols, and they've been labeled by clinicians as good or bad. Now your high density lipids are quite small, okay, because they're high density, so they're small in mass. And what happens with these particular ones is these are the cholesterols that, the lipoproteins that actually will pick up fatty acids from the bloodstream and deliver it back to the liver in order to be broken down into glycerol to be used as energy. Okay, so therefore is removing fat from the bloodstream, minimizing the risks associated with hyperlipidemia, causing plaques to get bigger, that sort of thing. So that's why they've been given the term good cholesterols. Now your LDL cholesterols, they're the opposite, so they've been deemed bad. These are the lipoproteins that will actually carry large amounts of fat, okay, therefore having a low density because they're holding a lot of fatty tissue. Then it will move from the liver to the actual cells, okay, and then actually implantation, like a flat smear, is actually what they'll produce by transferring it from the liver all the way to the cells. So because they are associated with moving fats into the blood in order to get to the cells, they've been deemed your bad cholesterol. Now triglycerides, they're your mainly your abundant dietary lipids, and the way they work is there's two other types of lipoproteins that don't often get a lot of credit. Okay, so there's your very low density lipoproteins, and they're mainly what triglycerides are. Now very low density means the triglycerides are a very large base lipoprotein, and we also have a chylomicron, okay, and that one there is the largest of all the lipoproteins. So when we take a blood test, what we are looking at is we're looking at obviously HDL, your good cholesterols, your LDL levels, which is your bad cholesterols. We look at triglycerides sort of as your backup or total fatty deposits within your blood, and then we look at total cholesterol. Now, total cholesterol includes all the lipoproteins that I've mentioned. Now those four are the main ones, but then from there we have another 5 or 6 subcategories as well. But that's the main thing we need to talk about when we're dealing with cholesterol itself. Now the other test that is quite important, especially when we start giving medications for cholesterol, is we need to have an idea at somebody's liver function, either at the start and then especially when we keep giving these particular ones, because most of the drugs we talk about has some form of effect on the liver or the biliary tract itself. So the liver function test is just that. Okay, it's a blood test used to diagnose or monitor the actual liver disease or damage to the liver. Things that it tests are things like your protein. So you can have specific ones like albumin, and that will tell you how much albumin is actually being produced by the liver. Now that is the main protein that the liver actually produces. So it's a good one as a marketing agent to tell if the liver is synthesizing proteins at a relatively normal rate. The other tests look at a huge amount of blood liver enzymes. Now the top two, alino-amino transfers and aspartate amino transfers, they're associated with enzymes that are mostly found in the liver. So if you have liver damage, these enzymes are going to leak out into the actual bloodstream. Now they are found in other areas like the heart, okay, but mostly they're found in the liver. Now your gamma glutamine transferase and alkaline phosphatase, they're also liver enzymes, but they're more associated around the biliary duct. So if there's any problems associated with the biliary duct or bile transfer, things like that, then these two will be raised. Also fatty acids and fatty livers and things like that. Now bilirubin is another test that can be done. Now obviously that's this byproduct of broken down red blood cells that gets pushed into the liver via the biliary duct for excretion. So you can either have a total bilirubin, a direct or indirect number associated with it. From there we can look at other things like total protein, which will look at your fibrogen and also your albumin, things like that. And you can look at clotting factors as well, prothrombin time and that sort of thing. So that's what the breakdown of the liver function test is looking at. The main thing associated with liver damage is looking at those first two liver enzymes, okay, the ones associated with liver cellular destruction. That's the main one that gets monitored when you are giving your main medication or your statins themselves. Okay, from there we can finally look at our patient. Okay, so things that people have to be aware about when starting on medication is, first of all, medication is not the only treatment, and it's also not the primary treatment for high cholesterol. So certain things in people's lifestyle can dramatically increase the probability of having high cholesterol. Okay, so we have diet plays a big role. Now someone's family history also makes a very big, significant risk associated with high cholesterol. Now from there you look at someone's overall weight, because we've got to deal with blood flow and use of energy, things like that. If someone's a smoker, prolific alcohol user, they all have effect on either liver synthesis, or the smoking has a direct effect on the endothelial layer, increasing the probability of atherosclerosis. Okay, so we need to look at those and educate on lifestyle changes is the main thing. From there we need our data. We need other risks from a medical point of view. Okay, so we need to have a look at somebody's medical conditions. So kidney, liver diseases, biliary obstruction in the past, a risk of cholelithiasis, anything like that that will affect the functioning of the liver needs to be taken into account. We need to know their cholesterol standing and their baseline liver function test, as well as their BP and their pulse associated with cardiac output. Hypertension is also a very large risk associated with atherosclerosis and plaque formation. Now, a very important thing to note is the medications associated with cholesterol management are not to be given to pregnant women or anybody or any female, breastfeeding. So high cholesterol is a problem associated with pregnancy, but we cannot utilize the medication whilst they're in their pregnant or lactating state, just to let you know. The client needs to be aware that these medications are not short-term. They are not a short-term fix, and they involve complete compliance or adherence with the medication and also the lifestyle changes that you'll be discussing. Now, they can take a long period of time to actually kick in. Okay, we're looking at a minimum of 4 weeks, but sometimes up to 8 weeks, and that is just to reduce the actual cholesterol that's being produced. There is some studies that suggest that in the space of 8 to 12 months use of statins, you can actually reduce the overall cholesterol and plaque formations that are already formed. Okay, so clients need to be acutely aware that this is not a course of antibiotics that you take. This is a long-term commitment in order to prevent the probability of hyperlipidemia and therefore ongoing cardiovascular disorders. Once you have all your data together, you need to implement that. You need to have a plan of education. Now, part of those we've already talked about. Okay, so we need to give the client education on the medication, emphasizing the role of diet and lifestyle changes as well. Okay, so that's the main one that our education needs to be. We also need to tell them that they need regular monitoring of their lipids and liver function tests, depending on the drug that they take, in order to make sure that they're not getting any adverse effects and that the actual regime that they're on is adequate to lower their cholesterol. And that comes into your evaluation. We need to look at if the effectiveness of the drug is working, if it's actually meeting the goal, which is reducing the levels to a normal state. And we also need to make sure that there isn't any extreme adverse effects associated with the medications that we're giving. Now, what those side effects are, we'll speak about when we start talking about the absolute specifics of the medications that can be utilized. So the first and main drug that is utilized is your statins. Okay, so statins are a class of drugs. They're also known as a HMG-CoA reductase inhibitors. Just to let you know, now to make it easy, people often call them colloquial term of statins because all of the drugs associated with it, like your atorvastatin, simvastatin, peruvastatin, they're all end in the term statin. So any drug that ends in the term statin will have this same effect and will be the same class of drug. So they are responsible in lowering the rate in which cholesterol is produced. That is their primary role. And the way they do that is they actually block the enzyme that is associated with turning your HMG-CoA enzyme and acetate into cholesterol itself. So it stops it right at the start as part of the formation that is used in the energy cycle, is also utilized to produce hydrogen-rich enzymes, CoA enzymes for the Krebs cycle, and also cholesterol. And this enzyme comes along and just inhibits that particular step in order to stop cholesterol being produced. So that is its primary role. Now, as a byproduct, and a very useful byproduct, because the cell registers a very low intracellular cholesterol. Now, just to remind you all, within the cell, cholesterol can be utilized to synthesize hormones. It's also used in the production and storage of vitamin D, along with a lot of other minor things. It plays a big role in the steps associated with a lot of intracellular synthesizing processes. So because of that, the body will naturally produce a number of LDL receptors. Okay, so remembering the LDLs, the ones that are actually floating around traveling towards the cells. So increase the amount of those LDL receptors, hoping that they can pick up some LDL because it's not being produced inside the cell. Okay, so that's the secondary role that it does. So by producing more receptors, it increases the probability of picking up LDL from the blood. Okay, and the last effect that it can do is it decreases the secretions of very low density lipids. Okay, so very low density lipids cannot be produced in the absence of intracellular low density lipids. Makes sense? You need a bunch of low density lipids in order to bind together with a different lipoprotein in order to produce your very low density lipids. So as a third effect of your statins, it will reduce that. Now the effects overall hopefully it will lower not only your LDL cholesterol by having increased receptor zones to pick them up and stopping VLDL being released, but it'll also have an overall effect on total cholesterol. We can also note here that it doesn't have any secondary effects associated with your high density lipids, which were your good cholesterols. So it makes it a very useful and a very commonly used medication in the management of cholesterol. Things that you need to be aware of when giving the statins, moving away from the pharmacology now. So things a patient needs to be aware of is it's going to take 4 to 8 weeks before the cholesterol level will come down. Okay, and you should have your lipids measured around the 4 to 8 week mark as well. Now, after that, the level should be reviewed every 6 to 12 months. Okay, should be reviewed every 6 to 12 months. The patient needs to be aware that in the presence of liver disorders or high intakes of alcohol, these statins are going to be reduced and can cause problems. It's best to take these particular ones at night, as cholesterol is actually mostly synthesized when the body is at rest. Now, the main side effects associated with this one is you can get liver changes. Okay, so you can get a slight increase of your liver function test. You can get your general GI, constipation, diarrhea. But the main ones to look out for this one is myopathy, so muscle pain, and also rhabdomyolysis. So in the event that someone gets rhabdomyolysis because of the use of statins, they often change to one of the other regimes. So the way to keep control of that is by keeping an eye on the liver function tests and checking your creatine kinase as well in order to monitor the symptoms, because it's not a profound acute rhabdo, it's more of a slow forming one. Okay, other medications can be used because they're not used as much as the statins. Okay, so they're in the top right corner in the purple, that's their functions. So we'll just have a talk about the other drug classes and what they do. Okay, so we'll start at the top and we'll look at our anion exchange or our ionic exchange resin. Now these particular drugs are kind of cool. Okay, well I like them anyway. Now the cool thing about these particular ones is they actually bind to your bile acid. Okay, so they're often also known as your bile acid binding resin. Now this particular group of medication will actually bind to the bile salt and allow that salt to be excreted rather than recycled in the liver. Now the reason that it's good to get rid of bile salt is when you get the bile salts in there and they go through reabsorption in the liver, they actually act as a pseudo-emulsifier of fats like cholesterol, and that being an emulsifier, so bringing in all those cholesterol, actually makes it easier and more readily available for the body to create plaque and fatty acids. Okay, so if they have a high probability of forming plaques in the bloodstream, by stopping the action of the bile salts, then there is no emulsification and the overall total level of cholesterol in the blood will reduce. Okay, now these particular ones are often used in conjunction with your statins if a simple statin isn't able to control it. Moving down, we'll look at our estabimide, the bottom one associated with the orange box. Okay, now these particular ones, these stop cholesterol right at the source. Okay, so they're very useful. So they actually will block the absorption of your biliary cholesterol. Okay, and they inhibit the transfer across the actual intestine wall. Now, there's a lot of controversy lately of these ones. You can actually read some recent studies on these inhibitors of cholesterol. It was thought for a long period of time that they don't actually do anything at all in controlling or lowering the overall cholesterol in the body. Okay, obviously because we mentioned that only 15% of cholesterol comes from diet, therefore absorption within the bowel. But a recent study has shown promise that they are the only non-statin cholesterol lowering medication that has shown the ability to decrease the risk of cardiovascular disease as well as statin. Okay, so that's kind of cool and kind of recent studies as well, just to keep us in the loop. Let's see, your fibrates, okay, or your fibric acid derivatives. These ones are a little bit unknown. Okay, well, what they believe that they think they do is one of those drugs that was created because it had a really cool byproduct of reducing the synthesis of triglycerides. So they're not 100% on how that physically works. They just know that when people take it, their overall triglyceride level decreases. Okay, it has a few other benefits associated with it. So it also has secondary effects of platelet aggregation. So it inhibits platelet aggregation and it increases fibrinolysis. Now, normally, in normal stasis, if people aren't bleeding, this is very, very useful, okay, because if we don't have platelet aggregation and we have fibrinolysis, then we are going to break down clots and we're going to stop the formation of other clots associated with atherosclerosis. And obviously, some of the side effects associated with these ones can be bleeding. Okay, so it is a good idea to monitor hematological values like your hemoglobin and your platelet levels, just in case we start getting small bleeds in the body from taking these particular ones. Now, the last one that we'll talk about in this class is your nicotinic acid. Okay, now they're similar to the last group, okay, your fibric acids, and these ones also reduce the production of triglycerides and give rise, so they actually stimulate the rise of high density lipoproteins. Now, these particular ones are not used very much, not because they're not effective, but just because they have to be given in such high doses. Now, these high doses have a strong association with itchiness and gastrointestinal irritation, as well as a pretty big side effect of vasodilation. So it can actually cause vasodilation, especially if given with an antihypertensive medication. So they seem to increase the hypertensive medication that is being used. So needs to be careful because quite often someone will be on a cholesterol and a hypertensive medication at the same time. Okay, so that is your overview of hyperlipidemia. So right at the top of what cholesterol is, how it's formed, how we monitor it, considerations for the patient, and then finishing off with the different classes of drugs. I hope you got something out of it. If you haven't already had conversations with people taking cholesterol medication, then I'm sure you will. They're becoming very popular, and cholesterol problems and cardiovascular problems are either maintaining or seeming to getting a little bit worse depending on the studies that you read. So it's going to be a big topic, at least for another 10 years. But until next time, take care.